Hi friends, good evening. I'm Dr. Ashutosh Gupta and I'm a consultant fetal medicine. So today we are going to talk about an evolving cardiac lesion in the background of a skeletal dysplasia in the fetus. Right? Okay, so we have spoken in length about the skeletal dysplasias. Okay, so whenever we measure the length of the bones and then we identify that we put all those things onto the graph, right? And whenever they touch the -4 SD, and therefore we have got a very strong suspicion of it being a skeletal dysplasia first. Now this diagnosis of mild micromelia or could be in skeletal dysplasia. There could be 7 8 varieties of skeletal dysplasias. They can be usually made at something around 30 weeks around and all those time, right? And now, why I want to share this sort of a video with you people is to identify that when we kept the baby under follow up, and then we asked that lady to come back after 4 weeks, and then we identified that there were some issues which really changed the whole of the situation, clinical situation at hand, right? So I'm going to tell you that there was some cardiac lesion which was not earlier there, and then it had developed, right? And therefore it has changed our clinical sort of dimensions. How do we manage the case? Okay. So this is the biometry. We are this baby in a follow up. It is at 34 weeks, and we identified that this is skeletal dysplasia. This is the fetal weight, so very severely IUGR baby. The baby is not growing. This is the biparietal diameter, which is 50th centile. The head circumference also is at 50th centile. Then we look around for the abdominal circumference. Then we look around for the abdominal circumference, and then we identified that this is the baby is not growing. Right. This is the femur, which is at -4 SD. Right. And this is the tibia, which is also very low, -4 SD. And this is the humerus, the arm bone, which is also at -4 SD. Right. And then this is the radius. So all the bones are at -4 SD. So this is for all practical purpose skeletal dysplasia. At 34, we identified that this is a mid-phase hypoplasia that we identified. So it was expected. Now this is a finding that was not expected. This is the right ventricular strain. We identified that the right ventricle is hugely dilated. And then we look around for the pulmonary artery. You see that there is pulmonary artery stenosis, right? And then the main pulmonary artery is getting stenosed, and then we are having a post-stenotic dilatation. So you are having this post-stenotic dilatation. When we put the color, we identified the aliasing is there, right? You identify the aliasing which is there in the main pulmonary trunk, and which suggests that it is very high flow, and this is the post stenotic dilatation. Okay, so this pregnant lady is coming in a follow up. Okay, so meaning thereby that all those things of an skeletal dysplasia has been told to her at something around 30 weeks or so, that the limbs are not growing and all those stuff and blah blah blah, right? It is at -4 SD, and therefore there could be some suspicion of a mild micromelia and all those stuff, right? And then probably we keep the baby under follow up and all those stuff, right? Okay, so all those things has been counseled very well. Now she had come for a follow up at 34. Now what we've identified something is this, that we've identified that there is some issues regarding the heart, right? So it is getting into a right ventricular sort of an strain, and right ventricle is getting dilated, and then we try to look around for, and then we identified there is a pulmonary artery which is getting stenosed. We are having aliasing. The flow across that pulmonary trunk is also -120 centimeters per second, which is highly suggestive that it is an stenotic lesion. Then we are having a post-stenotic dilatation. We are having aliasing of the color flow, right? So meaning thereby that skeletal dysplasias babies, they usually do well. They don't have any issues regarding they don't need any ventilatory support or a cardiorespiratory support. As a matter of fact, once the cardiac status is all clean and clear, right? But this single finding has really changed the paradigm, meaning thereby now we are asking her to deliver at a tertiary care center, in which the pediatric cardiology tertiary care referral center, where this pediatric cardiology services are available, right, all 24 hours. So meaning thereby that this is at 34, meaning thereby that 2 more weeks are there, and therefore there could be some finite possibility that the baby might come as cynosed. And since it is a pulmonary trunk which is dilated, and so meaning thereby that might be possible that probably the baby might need some sort of an cardiorespiratory support, as a matter of fact, immediately after the baby is born. So skeletal dysplasias is this, that there we are identifying the lesion could be lot many and all those stuff, but in a smaller perspective, we can identify that this is all collagen. The great vessels of the heart are also like out of the pulmonary trunk. They are also, they do have this collagen, lot of collagen into their walls and all those stuff. So meaning thereby that this this cardiac lesion and then the skeletal dysplasias, they go hand in hand, meaning thereby that we can have some collagenopathy in the background that is leading to skeletal dysplasia, and therefore at 34 weeks we are having some sort of an fusiform dilatation or a stenosis at the major pulmonary trunk, and therefore we are having this dilatation, right? So, meaning thereby that this is not something which is a part of the continuum, meaning thereby that this collagenopathy can lead to skeletal dysplasia. Vis-a-vis, this can also behave. This can also have some cardiac manifestations also. And if we look around in all these things, and therefore it might fit into a Noonan syndrome, right? And therefore, so that is how it is. So, meaning thereby that this single finding has really changed our sort of an mm, the management, clinical management, meaning thereby that the baby now might need some sort of an cardiorespiratory support and needs to be delivered at a tertiary care center. And therefore, this is to highlight not all the cases would have those sort of an coarctation of aorta or pulmonary artery stenosis and dilatations, but if we do identify, so meaning thereby that probably we should keep a close eye, and then fetal medicine specialists doing those ultrasounds at something around 8th month. It is pertinent and very, very important, so as to triage the babies across and then for identify, and therefore we can triage the fetuses, and then we can really prognosticate them antenatally, right? Thank you very much for your patience.